Hi, I am Dr. Susovan Halder from Kolkata. I have 30 years of clinical experience. I'm an MBBS followed by a DT M and H from School of Tropical Medicine and MD. I am a life member of API, RSSDI, and Critical Care Society of India, and I am a consultant physician. Today, I am going to talk about initiation of combination therapy in a recently diagnosed type 2 diabetes patient whose HbA1c has not been controlled over the last few months after the diagnosis. There has been a paradigm shift in the concept of treating diabetic patient. Here is an example, a 45-year-old newly diagnosed type 2 diabetes who visited the clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. This is standard of care. So recently he visited again as part of a routine checkup. His laboratory workup showed the following reports: A1c 8.5%, that is 1.5% above the target, because all the guidelines are saying for almost all the patients without comorbidities, it should be less than 7%. eGFR 80, LDL 80, HDL 38, and triglyceride 200 milligram per deciliter. He is on the following medications: metformin 1000 milligram BID, lisinopril 40 milligram OD. Nowadays, a lot of ARBs are used in our country. Metoprolol extended release 100 milligram once daily, atorvastatin 40 milligram, and aspirin 75 milligram. His BMI is 31, grade 2 obesity. Blood pressure is 120/70, and heart rate is 78. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications of type 2 diabetes. This we have come to know from the landmark study, the UKPD study. That study has guided us about controlling the HbA1c, which immediately translates into reduction of microvascular complication. And it also, the long-term follow-up of the study demonstrated a legacy effect of early intensive therapy, because the difference in CV event rate 10 years post-trial was apparent, even though no difference in A1c level between the intensive and conventional therapy. So early intensive glycemic control is of paramount importance. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline A1c. Empagliflozin is an SGLT2 inhibitor and linagliptin is a DPP4 inhibitor. Both the drugs have shown remarkable efficacy and pleiotropic benefits to our diabetic patients. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of less than 7% compared with metformin monotherapy. For patients with A1c more than 1.5% above the goal at diagnosis, ADA and EASD guidelines recommend first-line treatment with a dual combination and an SGLT2 inhibitor as a first post-metformin treatment in patients with established CVD, CHF, or CKD. The Empalina combination with complementary mechanisms and pleiotropic benefits may be a suitable option across a range of patients, especially our patient is obese, and including those with established CVD or high risk, established heart failure, or CKD due to their tolerability. The excellent tolerability of the combination, in addition to the potential benefits of EMPA on cardiovascular and renal outcomes, and no increased risk of heart failure with either of the agent. In fact, empagliflozin reduces hospitalization for heart failure, whereas linagliptin is neutral to heart failure. According to the study, early achievement of A1C less than 7% with empalina could reach target A1C at 12 weeks compared to monotherapies. There has been numerous trials, international trials with this combination. A1C decrement by empalina 25/5 has demonstrated 1.81% A1C reduction at a baseline A1C more than 8.5% at 24 weeks in metformin-treated groups. The benefits on glycemic control were maintained at 52 weeks in metformin-treated group, and a higher percentage of patients achieving A1C less than 7% were reported for combination. The combination offers a suitable component in strategy to achieve target A1C without increased risk of hypo and weight gain with improvement in overall lipid profile. A reduction in the incidence of genital infections. We all know that SGLT2 inhibitor increases the incidence of genital mycosis, but surprisingly, the combination of SGLT2 inhibitor and DPP4 inhibitor reduces the incidence of genital mycosis as compared to SGLT2 alone. So in summary, EMPA-LINA combination provides robust A1C reduction and a 2 to 4 times higher odds of patients reaching the goal A1C compared to individual agents with low hypoglycemic risk. So the risk of hypoglycemia is low. There is a robust reduction of A1C with pleiotropic benefits, mainly from empagliflozin, and a safe drug like linagliptin, which doesn't require any dosage adjustment. So when you think of initiating treatment with a combination of SGLT2 inhibitor and a DPP4 inhibitor, this combination of empagliflozin and linagliptin should come to your mind first because of robust data with this combination from several international trials. Thank you very much for your patient hearing.